The common definition of a fracture is a solution in the continuity of a bone. Such a definition, however, represents only a small part of the therapeutic problems involved. We must remember that every fracture has a patient attached to it. The patient has a life, a family, a job. We must take into account whether the patient is a child or an old man, whether the fracture involves the hand of a pianist, which must be functionally perfect, or a watchmaker's foot, which is unimportant to his work. Similar symptoms following identical wrist fractures may mean complete disability to this man and little or none to this man. Therapy is inadequate when restricted to broken bones. Our aim must be to treat the patient as a whole, to restore him to his normal activities as soon as possible and as completely healed as possible. We must cure the patient, not merely the X-ray. A fall on an outstretched hand may produce a variety of fractures of the upper extremity. There may be a Colles fracture, a fracture of the scaphoid, or both. The same fall on the hand may produce a fracture of the supracondylar region of the humerus, the shaft of the humerus, the upper end of the humerus, or especially in children, the clavicle. Injury to the hip by a fall on the trochanter may produce an impacted fracture with the head assuming a valgus position. On the other hand, a displaced varus fracture of the femoral neck usually is the result of indirect violence. It is the cause of the patient's fall, not the result. A fall on the feet may produce a heel fracture by direct violence and may be accompanied by a spinal fracture when there is a sudden jackknifing of the trunk. A further complication which may be present is an acute abdomen due to retroperitoneal hemorrhage. Violence to the knee produces fairly constant results. Force from the side may rupture a ligament. It may break a bone, or both. If the force... Similar forces to the bones of growing children often fracture an epiphyseal plate. Forcible inversion of the foot may rupture the lateral ligaments, avulse a fragment from the fibula, and if the force continues, shear a fragment from the tibia. On the other hand, forcible eversion may produce an avulsion fracture of the tibia or rupture the medial ligament and cause a shearing fracture of the fibula. Another serious fracture is this one, involving the lower third of the fibula and rupture of the lower interosseous membranes and ligaments, accompanied by a fracture of the internal malleolus. This is commonly referred to as the Potts fracture. Forward momentum produces a backward thrust of the foot that may fracture the posterior lip of the tibia. A fracture occasionally results from an inadequate trauma. When this is indicated from the history, we should always suspect a previous pathological weakening of the bone. No treatment can be rational unless the surgeon understands what has happened within the envelope of the skin. Tearing of the periosteum is to be expected and does not interfere with reduction. However, sometimes a buttonhole penetration of the periosteal sleeve by a bone fragment may make manipulative reduction more difficult. Tearing of muscle and even fascia is common, but sometimes there may be a penetration of muscle and fascia by a bone fragment which may make reduction impossible. Wide displacement should arouse suspicion of interposed soft tissue. Absence of crepitation confirms this. A fragment may even penetrate the skin itself. Regardless of the size of the wound, compounding from within is as dangerous as from without. Another complication of grave importance is the rupture or constriction of blood vessels by a contiguous fracture. Equally serious is injury to a contiguous nerve, either by contusion, stretching, or laceration. Fractured ribs may also result in complications. When they puncture the pleura or lungs, the fracture becomes unimportant compared to these pleural and pulmonary complications. Comparably, a crushed pelvis may produce various injuries, each of which requires immediate treatment. There may be complications in the bladder, urethra, or lower bowel. We must understand how nature repairs the lesion and how we may relate the progressive steps of our treatment to the sequence and timing of healing. When fracture occurs, there is set in motion a continuing train of events. The first thing that happens is hemorrhage, which causes local swelling. To the collection of blood, there is rapidly added lymph and inflammatory exudate. Within the first few hours, a clot is formed. Tissue shock initially may relax the surrounding muscles so that they're soft and elastic. However, within a short time, they go into spasm, and throughout the first 24 hours, they absorb fluid and progressively become hard, swollen, and inelastic. But from the very moment of fracture, dead tissues and decomposed blood are steadily autolyzed and eliminated through the minute venules and lymphatics. Simultaneously, new cells begin to grow into the fibrinous framework of the hematoma. The toxic products of protein disintegration mobilize a local inflammatory reaction accompanied by acidity of the tissue fluids. During this stage, calcium is extracted from all available local sources, including the bone ends, and goes into solution in the surrounding fluid. With the elimination of tissue debris, the inflammatory reaction subsides. As the pH returns to normal, the calcium is precipitated into the immature, undifferentiated ingrowing cells. When these cells contain enough calcium to show a shadow by X-ray, it is called external callus, which is a kind of natural splint around the fracture. But if a return to normal pH is delayed, many of the ingrowing cells may mature into fibroblasts to produce an imperfect callus. Normally supported by the callus, the same process goes on more slowly in the region directly between the broken ends. This forms an internal callus, which gradually assumes the pattern of normal bone. Coincidentally, the external callus may grow smooth and dense and shrink in size. Our first duty in treating a fracture is to avoid delay. Preliminary sedation may be given to reduce muscle spasm and prepare the patient for the general or local anesthetic indicated by the clinical circumstances. In many cases, a light, short, general anesthesia is most efficient. When local anesthetic is indicated, 1% procaine hydrochloride supplemented with morphine may be adequate, but only if carried out early. Part of the hematoma is withdrawn and replaced with anesthetic. During this fluid phase, the anesthetic can be brought into contact with all the injured tissues. But if more than 24 hours have passed, the anesthetic may reach only some of the injured tissues. Following injection, wait at least 15 minutes for the anesthetic to reach its maximum effect. The fracture may then be manipulated. In reduction, we must overcome muscle spasm. During the first 24 hours, gentle or steady traction will finally tire and relax the muscle fibers. However, if treatment has been delayed more than 48 hours, the muscles, shortened by spasm, become rigid and inelastic. Traction must then be powerful enough to tear the inelastic fibers apart before restoring length. This procedure increases the local tissue damage and retards the healing process. Sudden or unsteady traction such as this will increase rather than decrease muscle spasm. The method of traction often depends upon the strength of the muscles to be overcome. Manual traction against counter traction is usually the choice. However, there are other methods. At times, gravity may be utilized. For a mild pull, skin traction is adequate. For a comminuted fracture or oblique fracture, traction is needed not only to accomplish, but also to maintain reduction. To overcome the stronger muscles, traction may have to be skeletal. In most fractures, we must deal with some combination of deformities. There may be angulation, displacement, overriding, rotation, impaction. All of these deformities may be present in a single fracture and should be corrected one by one. First, the impaction is loosened. Rotation and overriding are corrected. The displaced fragment is realigned. Finally, angulation is corrected. This fracture, for example, has all of them, and we can see the surgeon correct for impaction, rotation, overriding, displacement, and angulation. The green stick fracture requires a special form of manipulation. Here is a simple demonstration of the fracture. Because of the tendency of some of these deformities to recur, even in plaster, it is sometimes necessary to overcorrect so that the fracture can be accurately reduced and the reduction maintained. The most commonly unrecognized deformity is rotation of the fragments. If rotation occurs after the injury, it may be caused by the pull of gravity, as in this case. Sometimes the rotation is due to the muscles involved, as in this high fracture of the femoral shaft. Here, the only muscles attached to the upper fragment are the abductors, the external rotators, and the flexors. They tend to rotate the fragment into this position. Satisfactory control of this fragment buried under the bulk of soft parts is impossible. Therefore, we must bring the controllable distal fragment into line with the proximal fragment before completing reduction. Similarly, in the case of a high fracture of the radius, since there are attached to the upper fragment nothing but flexors and supinators, we must perform reduction with the elbow flexed and supinated. In many fractures, the associated muscles exert a force which not only contributes to the deformity, but also adds to the difficulty of reduction. In this case, posture can help. Flexion of the knee and plantar flexion of the foot shorten and relax the calf muscles and are an essential preliminary to the reduction of an ankle fracture. Compression fractures of the spine are also reduced by posture. Hyperextension decompresses the crushed vertebra by the pull of the anterior ligament. After reduction, the surgeon is naturally eager to see if he's done a good anatomical job. But the fluoroscope is a poor measure of accomplishment and should never be used to the exclusion of post-reduction X-ray plates. More serious is the fact that repeated use of the fluoroscope has a cumulative effect on the surgeon. This surgeon, for example, has cancer of the skin caused by improper use of the fluoroscope. Use the fluoroscope only in short flashes and always take post-reduction plates. After reduction, the application of a cast should be aimed at giving maximum immobilization to the fragments and minimum interference with the functions of the limb. The best form of immobilization is often a molded plaster splint. It is rolled out dry according to the measurements of the uninjured limb. The splint is folded and held this way. It is then moistened in water and squeezed gently to remove excess water. The splint is unrolled again on a flat surface, then pressed out to eliminate air pockets and to fuse the layers together. Next, it is molded to the limb, soft side in. The cast is overwrapped with a temporary gauze bandage to assure accurate conformity of the splint while the plaster sets. After the plaster has set, the temporary bandage is removed and a permanent dry one is applied. When use of a circular plaster is indicated, it is best applied over a stockinette. However, such inelastic circular casts are always potentially dangerous. The possibility of swelling under such a plaster demands constant observation. Any plaster dressing presents dangers which must be constantly checked. Hard edges of the cast are one potential source of trouble. Another source of difficulty is at bony points under the plaster. Use felt padding to soften the edges and protect the bony points by a felt donut. No matter how well this padding is done, however, frequent supervision is still necessary. This cast was a perfect fit at first, but on a subsequent visit, it was found that it had become too tight and impeded circulation because of swelling underneath. Test regularly for maintenance of circulation by observing the color of tissues distal to the plaster. Check temperatures as a further indication of a cast that does not fit properly. If swelling occurs, rebandage more loosely. As swelling decreases, rebandage more snugly. This is a good deal easier and safer than removing and replacing a circular plaster. Transient and migratory pains under a recently applied plaster are to be expected, but a persistent sore spot should be examined early, or it may turn into a pressure sore. Another thing which must be constantly guarded against is nerve compression. For the upper extremity, flexion of the fingers certifies the motor integrity of the median nerve. Extension of the wrist, the radial nerve, and spreading the fingers, the ulnar nerve. For the lower extremity, plantar flexion certifies the motor integrity of the posterior tibial nerve. Dorsiflexion, the anterior. Maintenance of function. That is the keynote of all treatment after reduction of the fracture. Don't wrap it up and forget it. Immobilize no structure, injured or uninjured, unless necessary. Remember, every fracture has a patient attached to it. The patient has a life, a family, a job. The best fracture treatment, therefore, goes beyond the X-ray and restores the patient to his normal way of living, as nearly whole as possible and as soon as possible.